I've been investigating a crisis that's hiding in plain sight: elderly malnutrition. What I've discovered through my research is both alarming and actionable. We're facing a global nutrition emergency among our aging population that demands immediate strategic intervention. Let me share what the data reveals. In 2021, over 97.60 million cases of malnutrition among the elderly were reported globally, a 1.2-fold increase from 44.36 million cases in 1990. This isn't just statistics. These are our parents, grandparents, and community elders facing serious health consequences. My investigation into global prevalence rates revealed shocking disparities. A comprehensive analysis of 98 studies with nearly 80,000 participants found the global prevalence of malnutrition in elderly populations at 18.6%, with Africa showing the highest rates at 35.7%, followed by the Americas at 20.3%. These numbers represent real people struggling with basic nutritional needs. What struck me most during my research was how this crisis varies by care setting. Malnutrition rates range from just 3% in community settings to approximately 30% in rehabilitation and subacute care facilities. This tells me we're dealing with multiple interconnected problems that require targeted solutions. I've learned that age itself compounds the risk dramatically. The highest mortality changes are observed in the oldest age group, those 85 years and older, with an average annual rise of 5.74%. This represents the cumulative vulnerability where physiological, medical, and social factors interact to compound malnutrition effects. The financial implications are staggering. My analysis shows that malnutrition-related healthcare costs continue rising, with Medicare and Medicaid increasingly covering specialized nutrition programs. But here's what gives me hope. I've discovered strategic interventions that work. Through my research, I've identified the most effective culinary intervention strategies. The Older Americans Act nutrition programs represent our largest systematic response. These programs serve nearly 1 million nutritious meals daily across the country through about 5,000 local providers. The data on effectiveness is compelling. What excites me about these programs is their measurable impact. Of participants in congregate meal programs, 74% believe their health has improved, 74% say they eat healthier, and 75% feel the program helped them live independently. These outcomes prove strategic nutrition intervention works. I've been particularly impressed by innovations in meal delivery technology. Home-delivered meal services have evolved beyond simple food provision. These programs now provide crucial wellness checks, reducing social isolation while ensuring nutritional adequacy. The volunteer delivery model creates human connections that address both nutrition and mental health simultaneously. My research revealed successful regional models worth replicating. Tennessee's Aging and Disability Network provided more than 3.5 million meals to older adults in 2024 through over 150 congregate locations, plus home delivery services. This demonstrates scalable implementation across diverse geographic areas. I've analyzed the economic sustainability of these interventions. Medicare and Medicaid may cover all or part of specialized meal delivery costs under home-delivered meals benefits. This insurance coverage transforms nutrition intervention from charity to healthcare, ensuring sustainable funding. The technology integration I've observed is revolutionary. Modern meal delivery services now offer culturally appropriate options, dietary customization for medical conditions, and flash freezing techniques that maintain nutritional quality. Silver Cuisine and similar services provide 150 rotating meal options specifically designed for adults over 50. What concerns me is the prediction for future needs. Estimates suggest approximately 29.64 million new malnutrition cases among elderly by 2046, despite declining incidence rates. This means we must scale interventions dramatically to meet growing demand as populations age globally. I've identified key success factors from my research. Effective programs combine multiple elements: nutritious meal provision, social interaction, nutrition education, health monitoring, and connection to additional support services. Single intervention approaches show limited effectiveness compared to comprehensive models. The cultural adaptation strategies I've studied prove crucial. Programs succeed when they offer meals matching participants' ethnic preferences, dietary restrictions, and familiar flavor profiles. One-size-fits-all approaches consistently show lower participation and satisfaction rates. My analysis of volunteer engagement reveals another critical component. Delivery volunteers provide not just meals but friendly faces and safety checks for homebound seniors, helping reduce isolation while ensuring timely intervention when health concerns arise. This human element cannot be automated or eliminated without losing program effectiveness. I've documented innovative funding models that enhance sustainability. The Nutrition Services Incentive Program supplements state resources based on previous year meal counts, creating performance incentives. Senior farmers market nutrition programs provide vouchers for fresh produce, connecting elderly participants directly with local agricultural systems. The emergency response capabilities I've researched prove program value beyond routine nutrition support. During COVID-19, established meal delivery networks quickly pivoted to serve isolated elderly populations, demonstrating infrastructure resilience that justifies ongoing investment. Looking forward, I see tremendous opportunity for technology-enhanced interventions. Mobile applications connecting elderly users with nutrition counselors, telemedicine integration with meal planning, and smart kitchen devices that monitor consumption patterns represent next-generation solutions. My conclusion from this extensive research is clear: elderly malnutrition represents both crisis and opportunity. We have proven intervention models, sustainable funding mechanisms, and scalable technology platforms. What we need is coordinated implementation and political commitment to treat elderly nutrition as healthcare infrastructure, not optional charity. The strategic imperative is urgent but achievable. By combining traditional community-based meal programs with innovative delivery technologies, cultural customization, and comprehensive support services, we can address this crisis systematically. The question isn't whether we can solve elderly malnutrition, it's whether we have the collective will to implement solutions at the scale this crisis demands.